Primary spontaneous pneumothorax. List of authors: Robert Smith, M.D., Samira Shojai, M.D., M.P.H., and David Feller Kopman, M.D. February 15, 2024. Case vignette: A man with spontaneous pneumothorax. Robert Smith, M.D. A 30-year-old man has presented to the emergency department with acute onset of chest pain on the right side and mild dyspnea on exertion. He has no relevant medical history and has never smoked cigarettes or abused other substances. He reports no trauma. On examination, he is afebrile, the respiratory rate is 21 breaths per minute, the heart rate 93 beats per minute, the blood pressure 128/80ths of a millimeter Hg, and the oxygen saturation 93% while he is breathing ambient air. The examination is normal apart from reduced breath sounds on the right side. A chest radiograph shows normal appearing lung tissue and a moderately large pneumothorax on the right side. The bones and the hilar and mediastinal structures are normal in appearance. Ibuprofen, 400 mg, is administered for the pain, and he is monitored in the emergency department. A repeat assessment performed at 90 minutes shows that his vital signs have remained stable and his pain is decreased. Now, at 4 hours, a follow-up chest radiograph shows that the appearance of the pneumothorax is unchanged. The patient is able to walk around the emergency department comfortably and his vital signs are stable. He expresses a desire to go home. He has an established relationship with a primary care physician at your hospital, and records show regular attendance at scheduled appointments for the past several years. You must decide whether the acute primary spontaneous pneumothorax in this 30-year-old man should be managed conservatively, with discharge of the patient home and reassessment at 48 hours, or whether a chest tube should be inserted. Treatment options. Which one of the following approaches would you take for this patient? Base your choice on the literature, your own experience, published guidelines, and other information. 1. Recommend conservative management with close follow-up. 2. Recommend insertion of a chest tube. To aid in your decision-making, we ask 2 experts in the field to summarize the evidence in favor of approaches assigned by the editors. Given your knowledge of the issue and the points made by the experts, which approach would you choose? 1. Option 1. Recommend conservative management with close follow-up. 2. Option 2. Recommend insertion of a chest tube. Option 1. Recommend conservative management with close follow-up. Samira Shojai, M.D., M.P.H. The man described in this vignette has had his first known pneumothorax. He has minimal symptoms that do not affect his activity. There is nothing in the history to suggest clinically apparent underlying lung disease and no indication that he would not return for needed follow-up if discharged. We presume that he also does not have a high-risk occupation, such as aviation or diving. As noted in the British Thoracic Society guideline, conservative management can be considered for the treatment of minimally symptomatic or asymptomatic primary spontaneous pneumothorax in adults regardless of size. This decision is supported in part by the extremely rare incidence of tension pneumothorax in this population and builds on the previous 2010 recommendation that was based on retrospective studies showing that approximately 80% of patients whose care was managed conservatively needed no further intervention. This 2023 update is also now informed by a recent randomized, controlled trial confirming the efficacy of this practice with some limitations. Specifically, the primary spontaneous pneumothorax (PSP) trial provided evidence that conservative management of primary spontaneous pneumothorax has a favorable safety profile and is non-inferior to interventional management in the resolution of pneumothorax. The PSP, primary spontaneous pneumothorax trial was an open-label, multi-center, randomized, controlled, non-inferiority trial in which 316 patients were assigned to an intervention group or a conservative management group. The primary outcome was lung re-expansion within 8 weeks as assessed on chest radiography. In a complete case analysis, re-expansion was noted in 94.4% of the patients, 118 of 125 patients, in the conservative management group, and in 98.5%, 129 of 131 patients, in the intervention group. Risk difference, 4.1 percentage points. 95% confidence interval C. 8.6 to 0.5 p equals 0.02 for non-inferiority defined by the lower boundary of the 95% confidence interval that fell within the pre-specified non-inferiority margin of 9 percentage points. However, in a sensitivity analysis with missing data imputed as treatment failure, a risk difference of 11.0 percentage points, 95% C, confidence interval 18.4 to 3.5, was outside the pre-specified non-inferiority margin. It is important to note that the conservative management group had a lower risk of serious adverse events or pneumothorax recurrence than the intervention group. Fewer days in the hospital and fewer surgical procedures. Although the findings of this trial pertain to a specific population, the patient in the vignette fits the criteria used for entry into the study. In the PSP, primary spontaneous pneumothorax trial, 85% of the patients whose care was managed conservatively had successful pneumothorax resolution without interventions. One of the benefits of this approach is the avoidance of hospitalization for multiple days in otherwise healthy adults. But patients such as the one in the vignette seem likely to benefit from a non-invasive approach even when this approach is compared with ambulatory interventional management. The randomized ambulatory management of primary pneumothorax (RAM-PP) trial included adults with symptomatic primary spontaneous pneumothorax at 24 hospitals in the United Kingdom, who were randomly assigned to have an ambulatory intrapleural device inserted or to receive standard guideline-based interventional management, aspiration, standard chest tube insertion, or both. Patients in the ambulatory cohort had a shorter hospital stay during the first 30 days but more adverse events than those in the standard care group. And despite pleural intervention, 21% in the ambulatory cohort needed an additional procedure. A low-risk patient with a likelihood of doing well without any intervention might avoid these adverse events and the need for repeated procedures. Indeed, it is speculated that intervening on the pleural space may exacerbate rather than solve the problem of pneumothorax. A recent hypothesis suggests that although chest tubes allow for rapid re-expansion of the lung, they create a conduit for negative pressure and exacerbate the pressure gradient. Whereas slower re-expansion, as occurs with conservative management, may allow for more effective healing of the visceral pleura. Therefore, in the absence of a high-risk occupation and after confirmation of the patient's ability to return for scheduled follow-up or for emergency care if needed, I recommend an outpatient non-interventional approach with close follow-up. Option 2. Recommend insertion of a chest tube. David Feller-Kopman, M.D. Spontaneous pneumothorax is traditionally categorized as primary or secondary, depending on the presence of underlying structural lung disease. This distinction has been challenged, however, given advances in imaging. Emphysema-like changes have been identified, with the observation of pleural porosity in patients previously thought to have normal lungs. Assuming that this patient truly has no underlying lung disease, he can be classified as having a primary spontaneous pneumothorax. Recent data suggest a bimodal age distribution for primary spontaneous pneumothorax, especially in male patients. with an early peak at 15 to 34 years of age and an increasing incidence after 80 years of age. Younger age may also be a significant risk factor for recurrence that is independent of sex or whether the pneumothorax is primary or secondary. Previous guidelines by the American College of Chest Physicians and the British Thoracic Society recommend intervention with either needle aspiration or tube thoracostomy as first-line treatment for large or symptomatic primary spontaneous pneumothorax. 2 recent trials showed that conservative management for primary spontaneous pneumothorax in patients whose condition is clinically stable may be a reasonable option. In fact, up to 85% of patients may not need further intervention. There are several caveats to consider, however, that reduce the general applicability of conservative management. The first is that in both the PSP and RAMPP, the randomized ambulatory management of primary pneumothorax trials, patients were highly selected. 2637 potentially eligible patients were screened to enroll 316 in the PSP trial. 4 in 776 potentially eligible patients were screened to enroll 236 in the RAMPP, the randomized ambulatory management of primary pneumothorax trial. Second, patients in the ambulatory group in the RAMPP trial had pleural drainage with an 8 French catheter, pleural vent, Rocket Medical, which, though arguably less invasive than a surgical 24 French chest tube, is only 2 mm smaller in diameter than a 14 French tube. For conservative approaches, patients must truly be asymptomatic or have minimal dyspnea on ambulation. Patients should have adequate social support and access to follow-up that is convenient in terms of distance from their residence and that might avoid a hospital visit that can last several hours. Physicians or allied health practitioners, or both, would need to follow up with patients treated in an ambulatory manner on a regular basis to ensure clinical improvement and appropriate triage if a patient's condition worsens. Recently updated British Thoracic Society guidelines suggest that the treatment of pneumothorax depends primarily on the presence of symptoms, as well as the patient's priority of avoidance of a procedure as compared with rapid symptom relief. Although this patient is asymptomatic and is in clinically stable condition, the combination of hypoxemia and a moderately large pneumothorax suggests that the most definitive approach is the placement of small bore, 14 French, chest tube now, followed by clinical and radiographic reassessment in 4 hours. If there has been improvement, the tube can be removed and the patient can go home with instructions for follow-up in the pulmonary clinic.